So with image interpretation, these are the things we usually cover, but of course image artifacts will be the next talk, and then of course in the context of stenting there's a talk after that, so we'll stick to just the first two. Now, anytime we do any intravascular imaging, we really see an axial cross-sectional image, and often we want to then communicate that in our report or to our colleagues, and we generally go the way histology does, and that's with a clock face. So, you know, the lesion is at 3 o'clock or is it at 7 o'clock, and that's a good way of looking at and describing these lesions, so remember that. It's also important that this is not just a single slice of an artery, although we often describe it as that. It's the whole artery, and one of the most important take-home messages from that is when you're doing a pullback and you're doing image interpretation, even before or after stenting, look at the whole artery. And we have now several different types of OCT systems that allow us to do it very well. Of course, for our intents and purposes, we're going to look at axial sections. And we need to think about a few definitions that are very important to keep clear so that you can interpret your images carefully. The first thing is backscatter, and that's when the light from the imaging catheter hits the vessel, the tissue affects what happens to the light, it's reflected back, and that reflected light is what creates the image. So if you have a tissue that has a high backscatter, that it scatters a lot of light back onto the catheter, you get a lot more pixels, so the image is bright. So like here in this plaque, this image is bright. High backscatter means a bright plaque. Whereas if the tissue doesn't backscatter, it absorbs the light a bit more, that tissue becomes dark, like it is here. So that's backscatter. The next thing is attenuation. And that means the reduction in intensity of the light as it passes through that tissue. There are tissues with high attenuation, which means that the light doesn't pass deeply and it gets quite dark, like here. Or low attenuation means the light will actually doesn't get attenuated, it passes through and you can see deeper and it's bright throughout. A few other things: composition. Is it homogeneous like this or heterogeneous? The texture, coarse or fine, and what's the border like? Is it a clear, sharp border like we see here through this bit of calcium, or is it diffuse border here in this lipid plaque? And we can put all of these together based on the type of character. Is it lipid, is it fibrous plaque or calcium, based on its backscattering and attenuation. OCT really came to fame with, you know, plaque vulnerability and all of that, and now has extended now into PCI. Let's look at a fibrous plaque. Now, if we look at backscattering attenuation, the fibrous plaque has very high backscattering, so it's really bright. It's also got very low attenuation, so the brightness extends quite deeply, and so it's bright right throughout. And you can then look at a fibrous plaque and then make that decision as to what its character is. What about a calcified plaque? If you look on our scale, and this has been done in histological sections, calcium falls here. It's low backscattering, so it's dark to begin with, it doesn't reflect light. It's also low attenuation, so it's dark throughout and gets even darker, and if you've got a big chunk of calcium, you won't see it distally. So heterogeneous, low backscatter, low attenuation, as we mentioned before, sharp borders. What about lipid plaque? Lipid, in fact, is on the other end of the spectrum to calcium. It's very high backscattering. So in fact, you can see this is the thin fibrous cap, which is fibrous, is bright, and just deep to that is the initial lipid layer, which is in fact very bright, despite what we think. It's actually really bright. And this is where there's confusion with macrophages and so on. But the problem is it's also very highly attenuating, so it becomes dark very quickly. And that's a good way of differentiating it sometimes with calcium, which with macrophages, where you can see some differences here. So it's homogeneous, high backscatter and low attenuation. And if you remember these, you can pretty much interpret most of your plaques that you see in your day-to-day practice. What does a normal coronary artery look like? Well, very much like it does in histology. 3 distinct layers: intima, media, adventitia. The first stage as we progress in atherosclerotic journey is that the intima gets thick, intimal thickening or intimal hyperplasia. This then becomes thick enough that it becomes a fibrous plaque. Now, fibrous plaque is really histological diagnosis, but in the context of OCT, if the thickness is sort of 500 to 600 microns and beyond, we say it's now become a fibrous plaque. Calcified plaques, we define what calcified plaques look like: sharp borders, heterogeneous, dark. And there are various types: very large chunks of calcium, large plates. You can have thin plates of calcium and spotty calcium. And you can very easily recognize the calcium based on those characteristics. Some algorithms now can actually tell you what the arc of calcium is, and we can measure how thick it is, and that has importance when we're looking at calcium modification and algorithms for that. What about lipid plaque? Well, here's a thick cap fibrous atheroma. You see this lipid, which is it's bright to begin with, but darkens very quickly. This fibrous cap is quite thick. This is another example of a thin cap fibrous atheroma. Is an old black and white image, and this was measured at 43 microns, the 65 cutoff from histology. And in this situation, we even did macrophage density in OCT raw data. So you can pick all of these when you're looking at your OCT images. With our current non-raw macrophages, what you see is a little signal-rich, distinct or confluent punctate regions. And how you differentiate that from a lipid plaque is often, it's got very sharp borders like this. And these are characteristic of surface macrophages. And they're just a very interesting thing to look at. Cholesterol crystals, high backscattering linear structures like this. The significance is not well understood, but probably